So it's my pleasure to invite Graham Barrett from Australia to talk to us about the free lunch, which is RayOne EMV.
My talk today is going to be on extending depth of focus, and I raise the question, should this be positive or negative, talking about some of the optics. And people often ask me, what made me choose spherical aberration as my first choice for extending the depth of focus? Now, there's several reasons, and the first one is the initial concept was, what is perfect vision? Perfect vision really is a balance of good resolution, but also adequate depth of focus. And when I looked at the optics and what you could do with optics, I felt that positive spherical aberration was the best principle to achieve the same. There's certainly unique features about positive spherical aberration. If you have some defocus due to myopia and you have some defocus due to spherical aberration, you put them together, there's a synergy, and the combined wavefront is actually better than either with myopic defocus or spherical aberration alone. Also, and this is often not well understood, all lenses are decentered to some extent. We actually don't know where we should actually put them. And if you look on the right, or actually on my left, looking at the screen, with the positive spherical aberration, with decentration, there's very little impact. The MTF is not altered. If you look at negative spherical aberration in contrast, even a small amount of decentration will drop the MTF significantly. So based on these principles, and it's not just simply adding positive spherical aberration, it's a sophisticated optic. It's a combination of fourth and sixth order aberrations combined over different optical powers, so the same effect is found across the entire range. And having this continuous curvature, but the amount of spherical aberration tapers off towards the periphery to maintain contrast with larger pupils in low light conditions. But using this principle, you can make a lens which gives you a tangible benefit, still falling within the ISO and ANSI standards for a high-quality monofocal lens. As Ron is alluding to, trying to get what you're having now, which is a free lunch in optics. So this is looking at the area under the curve, and you see for the simulated visual acuity for a RayOne EMV at 0.2 logmar, that's 6.9, there's really a good extended depth of focus, right up to minus 2.5 diopters. You can compare that to another so-called extended depth of focus lens, like the Pure C, which doesn't have a continuous curve. It has an annular ridge of increased power within the pupil zone. And you see it looks very similar. So this shows you that the terminology of enhanced monofocal and extended depth of focus is not really a proper distinction, because here you can see that the simulated intermediate and near is equal to what is so-called monofocal plus lens to a so-called extended depth of focus lens. Look at the MTF. You can see Vivity there, which is almost a 50% reduction in MTF. Some of the MTF is only distributed in one direction than the other. You can tell a lot about how a lens will perform clinically by looking at the MTF. One thing you can do, if you look at this paper by Gerd Arfath, is do resolution target and simulate directly, looking at the resolution target, the impact of that particular extended depth of focus lens. One thing is quite clear when you look at that comparison in Gerd's paper, that in order to get reasonable reading vision with all these extended depth of focus lens, you need to add some myopic defocus in one eye, if you look at the binocular defocus curve. And this is where the EMV is designed for exactly that. It's the right type of extended depth of focus to combine with myopic defocus. And if you're serious about providing near vision with extended focus lens, you should use some extent of modest monovision. If I did anything worthwhile, it's identifying an amount of myopic defocus, which I call the magic number, which is optimum. Because at -1.25 myopic defocus in one eye, you avoid asthenopia, it preserves contrast and stereoacuity, as opposed to what was often practiced, which was traditional monovision at -2. But what does the EMV add to the use with modest monovision? And I think it is fulfilling the promise that the patient expects of getting spectacle independence. If you target emetropia, you get more near and intermediate. But also, if you use some degree of myopia in one eye, there's less adverse impact on the distance vision in that myopic eye. Also, if you do a modest amount of monovision or minor amount, -3/4, you get more near than you would get with traditional monovision. And also, if you do use more monovision, say -1, -1.25, there's less impact on the distance vision in that myopic eye. This is a defocus curve from Tung Kwan in Singapore, and he did a comparative study using EMV with emetropia and using EMV with monovision. If you look at the binocular defocus curve for the emetropic eye, you can see even down to 40 centimeters, you can maintain 6/9 acuity. So it's a good defocus curve. But if you look at those patients who had modest monovision and look at their defocus curve, it's even broader. So the drop-off is much more, is further down the track, and you can expect good vision 6/6 for distance, 6/7.5 for intermediate, and 6/9 for near. So the blue line is the eyes, the binocular defocus curve for those with monovision. The red is the ones for emetropia. So even the emetropic eyes have a very good defocus curve. They are getting some useful near vision, good intermediate, but you can see how much more near vision adding that modest monovision with the EMV provides. This is not only for photopic, as you see on the one side of the chart, but even in mesopic conditions. They also did a questionnaire, a CAT-QUEST-9 questionnaire, and this shows that over 90% of patients in their questionnaire were able to read both small print for labels and also subtitles without glasses. So very good unaided vision. And even when it comes to reading on labels, it's 100% with modest monovision and EMV. It's still pretty good for emetropia in both eyes, 67%.
So now we're going to hear from our colleague, Dr. Anagha Heroor from Mumbai, who's going to tell us her personal experience and how she uses the RayOne EMV in her cataract refractive practice.
So what exactly happens when we use the EMV with the cornea in the periphery? The dip in the spherical aberration compensates for the increased spherical aberration in the cornea. So even when the pupil dilates in the mesopic pupil, the contrast sensitivity remains good. So it literally is a pupil independent lens. Many IOLs also rely on a very small central zone or use a combination of negative and positive spherical aberrations in the center, which means that in these lenses, the pupillary size and the centration of the IOL becomes very critical. Now, for example, courtesy Dr. Uday Degan, if you can see this small slide here, in the Vivity lens, it has a central 2.2 millimeter central zone. Now, if it's a pupil of 2.5 millimeters, literally 80% of the light goes in through the central zone, and the patient can suffer from dysphotopsia. Again, if you can see, if the pupil is slightly dilated, the patient would ideally be happier. But as the pupil comes down, the visual quality for distance reduces. And if there is a decentration in the lens, the patient actually sees through the transition zone, and the patient can have greater dysphotopsia. Similarly with the eye-hands lens. Now with the eye-hands, if you see if the pupil is around 2 millimeters, it gives a depth of focus. But 3 millimeters and beyond and larger, the optical performance is literally as good as a monocular lens. But with the EMV, in the mesopic pupil also, it gives us a significantly better depth of focus. Now, this effect of positive spherical aberration has an impact of a very good quality distance vision, similar to a monofocal. It has a myopic direction extension, which gives us excellent intermediate vision, and a hyperopic tail, which gives us a wider landing zone. So especially if you are targeting monovision, then you can see these three scenarios. The first is the 0.5 diopter offset, the second is the 1 diopter, and then you have the 1.5 diopter offset. So the binocular distance vision remains good, the intermediate vision goes on improving, and you can get greater functional near vision. So this was an interesting study which was done by Professor Ribeiro and Ferreira, and they compared the Rayner EMV, the Vivity, and the Symphony, which had all three excellent distance and good intermediate vision. But when you compared this with the Vivity, the significantly reduced glare and halos and the better contrast sensitivity of the EMV was highlighted. There have been a lot of peer-reviewed publications which confirm the optical principle, safety, and efficacy of this lens. Now, this was a newly published clinical paper which compared the effect of preoperative parameters, spherical aberration less or more than 0.4 microns, higher order aberrations, as well as the changes in angle kappa, and it was found that there was very little effect in the Rayner EMV for any of these parameters. In my personal experience, we have analyzed almost 72 consecutive eyes. If you look at the uncorrected visual acuity, 87% of them for intermediate vision were N8 or better, and 83 of them achieved N10 or better for near. We all know that we can achieve much better near vision when we target monovision. So to summarize, when we target for emmetropia in the EMV toric, we get excellent distance vision, very consistent intermediate vision, increased basically with the binocular summation in both the eyes, and a fairly good monocular near vision, but when you use monovision, then that near vision definitely improves. So to conclude, we can get excellent refractive outcomes which are accurate as well as stable. You have a wide refractive landing zone which can mask even small refractive errors. It's an excellent toric platform with minimum rotation, excellent contrast sensitivity, and negligible glare and halos. So all in all, a great lens for our patients.
One of the hottest lunch symposia was the launch of the Galaxy Spiral IOL. And so now a year on, we've got some experience, and Sri Ganesh and Michael Knorz are going to tell us about their experience. Sri.
So the new RayOne Galaxy Spiral IOL delivers a full range of vision with minimized dysphotopsia, like an enhanced monofocal. And this is a non-diffractive spiral optic where there is no light loss and there is a progressively elongated focus. It's also available in as a toric lens. This is the patented spiral optics. It's designed with AI. It's a proprietary AI engine trained on patient outcomes. And this has been used to create a new and unique optical spiral. So the optical concepts allows for precise control of the optical power from far to near focus. And it produces a smooth, full range of vision, unlike the diffractive trifocals, which have specific points of foci, distance, intermediate, and near focus. So how about patient selection and counseling? It's very similar to the trifocal lens. So eyes with significant pathology or high corneal aberrations, post-refractive surgery should not be considered. Dry eye should be aggressively treated pre and post-surgery, and the tear film is critical for all these lenses, full range of lenses, to get good patient satisfaction. These are our study and our results. This was a prospective investigational randomized clinical study. 32 eyes completed 15 days and 20 eyes 3 months. Inclusion-exclusion criteria, very similar to trifocal lenses. There's a contrast sensitivity. You can see that it's within the normal range. Even the higher spatial frequency is almost normal. If you look at the trifocal lenses, for the higher spatial frequencies, there's quite a bit of dip. So this is because the light loss is not significant. This is the defocus curves showing a smooth defocus and almost more than 2.5 diopters depth of field. This is the intermediate vision. It's pretty good at 40, 60, and 80 centimeters. Better at 60 and 80 centimeters. This is the uncorrected near visual acuity, and you can see that 90% have N8 and 80% have N6. This is the subjective questionnaire for visual disturbance, and all 10 patients were satisfied at 3 months with the distance and near vision. 9 out of 10 patients were satisfied with the intermediate vision. 9 patients reported glasses independence, and 8 patients reported no glare, and 2 patients reported moderate glare. These are leading questions. 9 patients reported no halos, and 1 patient reported mild halos. So the amount of dysphotopsia was less. When you compare it to the diffractive trifocals, where almost all patients, when you ask them leading questions, they say that they see the halos and glare.
Thank you very much. It's my pleasure to invite our last speaker for this lunch symposium, Michael Knorz, who's vastly experienced in all manner of really presby-correcting lens implants from Mannheim in Germany. Michael.
I will present 2 different approaches. Number 1 is an approach that actually enables you as the surgeon or every patient to actually judge yourself what the quality of vision is like by comparing different IOLs. There is an instrument which is available, built in from a company in Austria. It's called the Real Artificial Lens Vision. And as you can see, somebody, for example you, is sitting there in an instrument looking like a slit lamp, chin there, and looking through the actual IOL. And you can place several IOLs there, the Galaxy IOL, the Zeiss trifocal, or other IOLs, and compare the image with these different IOLs. And that's what we did with the Galaxy IOL. And here you see the comparison from the Galaxy in black trifocal lens and then enhanced monofocal lens first regarding the focus curve. And you can see very good performance without the trough in the intermediate distance. Number 2, you can actually compare the halo size. You see here the enhanced monofocal, which gives you the smallest halo, and you see the Galaxy, and there's actually no significant difference. But there's a much larger halo with a trifocal lens. So there is a difference which can be proved objectively as well. Contrast sensitivity, again, you can see that contrast sensitivity is better with the Galaxy than with the trifocal. The same thing Dr. Ganesh has just showed us. And then I think the most important part, what about the subjective preference? And this lists the subjective preference at distance. This is the distance target, intermediate target, and at near. And you can clearly see that the Galaxy is preferred by a vastly larger number of patients. 83% at distance, 80% intermediate, and 90% at near. And I agree with them. I looked through this instrument myself. It's quite impressive. Next and last step is the clinical results we have with the Galaxy IOL. No surprise, of course, uncorrected distance visual acuity and best corrected, very good. Now what about post-op when we look at distance visual acuity without any correction and intermediate and near? You do see, as expected, a little drop off the closer you come, but it's a very smooth curve, so very good results. When we look at the halos at day and night on a scale of 10, during the day it's just 2 on average, and at night it's 4. But what really counts is actually the comparison. And at the Euro Eyes group, we have a lot of experience. We have over 60,000 AT laser trifocal lenses implanted. And we compared here our data, Galaxy versus the trifocal. When we look at halos in the trifocal lens, 89% of patients often or always report halos. Only 6% had no halos. And with over 200 Galaxy lenses I implanted right now, we have 42% of patients observing halos, and 14% have no halos. So it's a significant difference. Of course, it's still a multifocal lens, so you do have some side effects. It's not an EDOF lens, but it's much less than with the trifocal lenses. So in conclusion, I do believe that we will see 2 developments. Number 1, we've seen the EMV lens presented by Graham Barrett, and I think these refractive EDOF IOLs will slowly replace monofocals. They offer more, but you don't have any disadvantage. So if you use them binocularly, both for distance, You get a good intermediate vision, as you just heard now, and Dr. Graham Barrett actually showed us combined with monovision that you can also use it for some reasonable reading performance. Regarding the Galaxy IOL, I do believe it will replace diffractive multifocal IOLs because it offers you much less side effects for the same performance. Thank you very much.
So Graham, I have a question for you. And I know that you were working in Brighton or Worthing on the different materials of the hydrophilic versus the upcoming hydrophobic material. Do you think that's going to make a difference in terms of contrast or clarity of vision, just the material-wise?
I don't think so, Ron. I think that's addressing people's caution using hydrophilic in certain circumstances. Hydrophilic actually is an excellent platform for optics. I don't think the hydrophobic will improve upon that.
Yeah, the Rayner EMV, I think, is an excellent lens, especially for post-hyperopic LASIK patients. I mean, this is my favorite lens for post-hyperopic. So for a post-hyperopic patient, they have a very high negative spherical aberration on the cornea. And then if you use any of the other lenses, most of them have negative spherical aberration. And it adds up. And then the quality of vision deteriorates. So when you put a Rayner EMV, it kind of tones it down, and the quality of vision is better. I think all of you all know about that famous Bollywood actor who got a particular EDOF lens with negative spherical aberration. He had hyperopic LASIK previously.
So negative on negative is bad.
Very unhappy, and he had to undergo an explantation. I think it was all over in the papers, and then I would have probably selected a Rayner EMV for him.
Sure. Last comment by Dr.
One question, in fact, just for the benefit of the audience, how forgiving is the Galaxy if there's a slight decentration?
Michael?
If there's a slight decentration, nothing will happen. The amazing thing is that the Galaxy is quite tolerant to decentration. And the key point for me, for my summary from this lens, is actually what is our worry when you use a lot of trifocal lenses or multifocal lenses? We use about 90%. We do thousands of patients every year. The main worry is distance vision. Many patients have, at least during the first year, problems at distance. And the Galaxy basically takes this away. So the complaints went down by about 80%. So that's a huge improvement. That's why I really like this lens. It helps me in my daily practice.